Hello, everyone. First, I want to thank you all for being here. This is our first ever Stanford Cancer Center Cancer Patient Symposium. I would really like to thank Amina Huda, Mary Kay Asuncion for all of their hard work and dedication in organizing and getting this event together. As you know, my name is Sharon Chin. I'm a physician assistant in the Department of Radiation Oncology, and I will be moderating our next session, which is the patient perspective. And we have three wonderful and courageous speakers who are here today. And they're here to share their prostate cancer journey. And so each of these individuals have chosen a different route following their prostate cancer diagnosis. And they will selflessly and honestly speak to you about their diagnosis, their decision, and their experience. Following each speaker, we'll hold a answer and question portion, so feel free to ask any questions that you might have, because this is also a part of your journey as well. So our first speaker is Mr. Daniel Odishu. He is a man of many, many talents. He has spent over 40 years in advertising, living in amazing cities like Chicago, home of Garrett's Popcorn, my favorite, as well as San Francisco. He has spent 15 years coaching girls basketball and has been married to his high school sweetheart for 57 years. He's a proud father of 4 children, stays active with 8 grandchildren, and those that know him know this saying: age wrinkles the skin, but to lose one's spirit wrinkles the soul. So, I guess I should tell you what he was diagnosed with. So he was diagnosed with low NCCN risk prostate cancer in 2012, and he has chosen to undergo active surveillance. As you may know, active surveillance is what we call watchful waiting, where time is allowed to pass before moving forward with medical intervention. During this time of watchful waiting, routine tests such as blood work, diagnostic imaging scans, and/or physical exams are performed to evaluate the possible progression of disease and to see when moving forward with medical intervention is warranted. So without further ado, I would like to have Daniel Odishu come up and do his journey.
Thank you. Good morning. As Sharon said, I'm Dan Odishu. I chose active surveillance as the best way to treat my prostate cancer. My journey with prostate cancer began in 2007, and now 15 years later, I find myself in a good place, both physically and mentally. Compared to some other men whose journey with prostate cancer may have been extremely difficult, I consider mine to have been relatively easy, primarily because my cancer was found in only trace amounts and was localized in only 2 places. Certainly there were decisions to be made to address the cancer, and each of them carried consequences that I had to consider and deal with. But all in all, I wouldn't change much, if anything, in the way I chose to treat my prostate cancer, so let me take you through my journey. I call the first leg of the journey the PSA only phase. It was a 5-year period between 2007 and 2011, during which a string of lab tests showed that my PSA was always higher than the 4.0 benchmark and always trending upwards to a high of 6.7 in 2011. I remember this being the one and only time I was actually scared about my prostate cancer, and it was a time when I didn't even know if I had it. Since my PSA scores could not tell me anything conclusive about my having cancer or not, I found myself in limbo, so to speak. And as an individual, I hate being in limbo. So when it comes to my health, especially, because my imagination invariably conjures up a scenario that's far worse, far scarier than the reality. I did a lot of reading on the subject, including consulting Dr. Google, but that only made me worry more, because there proved to be little consensus in the medical community regarding the value of PSA scores in predicting the presence or absence of cancer. I then entered leg 2 of my journey, which I call the biopsy phase. 6+ years in which my PSAs continued, my PSA test continued, but the doctors also performed 4 biopsies, one in conjunction with a prostate MRI, to try to determine if I had the cancer, and if so, how widespread it was. My PSA test continued to show rising levels, which crested at 9.2 in 2016. But 3 of my 4 biopsies found no signs of cancer, and the 4th biopsy found only trace amounts and found that the cancer was highly localized in only 2 of the 19 sections from which they took samples. I don't remember being scared at all upon learning that I had prostate cancer. Instead, I remember being relieved that I was finally out of limbo, and obviously even more relieved that my high PSA scores did not translate to a high level of cancer. As for my biopsies, they were nothing like I anticipated. They were actually quite pain-free and very little discomfort for me. I didn't like the injections around my rectum to numb me up for the procedure, but those were over pretty quickly. Taking the samples felt like someone was pinching me really hard with their fingernails, no big deal. And for me, the post-op was easy with no bleeding complications. Now the third leg of my journey, that began in late 2018 and continues to the present. Given that the doctors had found only trace amounts of the cancer and on only 1 of my 4 biopsies, for me personally, surgery and radiation seemed like overkill options. Surgery also carried with it a strong possibility that I might experience impotence and/or incontinence, and the latter was a nightmare scenario in my mind. Honestly, I rejected radiation probably more emotionally than rationally. I say that because the occurrence of both impotence and incontinence as a result of radiation were relatively small, but I just wasn't up for weeks and weeks of radiation treatments, and I could not get past the visceral reaction I experienced when I pondered the idea of radiation inside my body. I know it sounds crazy, but I actually reacted worse to the idea of radiation in my body than I did to the idea of cancer in my body. I can't explain it, it's just how I felt. So to treat my cancer, I chose an approach called active surveillance, which in my case calls for PSA tests every 6 months, as well as in-person doctor visits every 6 to 12 months, at which time my doctor conducts a rectal exam. I should also mention that during the same time, I have been taking medication to treat symptoms of my enlarged prostate, and although the medicine doesn't treat cancer, I know that, it is a constant which has been present through my entire active surveillance period, and it may have some relevance to some of my results. So what are the results? The rectal exams have shown my prostate has shrunk significantly and that I am clear of polyps. And my PSA has declined over time, with the last 4 most recent scores ranging between 2.0 and 2.9. While I have been told that the use of the medication for my enlarged prostate may in some ways mask my true PSA score, even if I were to double my recent scores, as many sources suggest I should do, my PSA levels would still be far less than they were when I began active surveillance. Since it's been a while, it may be time for me to consider a second prostate MRI or even another biopsy. My doctor and I talk about these possibilities at every appointment, the next of which is in the coming weeks. But net, choosing active surveillance as the approach to treat my prostate was the right decision for me, and I still feel that way. Before I finish up, I thought it might be helpful to discuss a specific condition that I have experienced during active surveillance period. This condition may just be the result of my getting old, or it may be that it's a side effect of the prostate shrinking medication I've been taking. But it is relevant to this discussion of prostate cancer treatment options because it can be a side effect of both radiation, there's a small possibility, and surgery, there's a higher possibility. The condition I'm talking about is impotence. Based on my experience and that of my friends who have had to face down impotence, I can say without hesitation that it can present a significant psychological challenge, one that plays with your male confidence and identity, and may also affect your relationship with your loved one if you've let it. The first couple of times I remember this happening to me, I lay awake looking at the ceiling, which thankfully had no mirrors on it, so I didn't have to stare at myself trying to figure out what to do about my problem. The first and most obvious answer was Viagra, but the thought of adding another pill to my regimen, and that pill in particular, just didn't appeal to me, though I can certainly understand its appeal for others. That's when I found an alternate approach, and for me, it's proven to be one of the best decisions I've made in a long, long time. What I decided to do was become a different kind of lover, less selfish, more patient, more thoughtful, more giving, and more creative. And I learned finally at this late stage in my life how much more enjoyment and pleasure there can be for both my wife and myself in my thinking of her first, instead of focusing on my satisfaction and on closure. I know what you're thinking. What the hell took this guy so long to figure that one out? So that's my prostate cancer story, and as I said at the beginning, I'm in a good place both physically and mentally when it comes to my cancer. It may not be the place many other men would choose, but so far it has worked for me. My doctor and I are actively surveilling my prostate cancer, so today, if and when I worry about other things. I wanted to offer 3 pieces of advice to both patients and doctors in closing, if I could. First, to patients, be the best advocate of your own health. Read, compile, and ask questions of your doctors, and keep asking questions until you understand. And don't say you understand when you don't understand because you don't want to look dumb. Remember, it's your doctor's responsibility to explain so that you do understand. I was in the advertising business for 40 years. The receiver of the message has no responsibilities in communication. Only the sender has responsibilities. So if I tell somebody something in an ad and they don't get it, it's not their fault, it's my fault. And to patients, it's your responsibility to yourself to create a dialogue with your doctor. Now, one thing I wanted to mention, we were just talking at the break, I'll tell you a little story to show you how we don't know what to ask. We just don't know what to ask. So I don't know anything about computers. I mean, nothing. So my computer was broken. I got on the phone and to helpline or whatever it was, and I got some individual in the Southeast, very nice young man, very smart, and he started to ask me questions, and I said, I don't have any idea what you're talking about. And he said, so he started, he dumbed it down a little. And I said, think of the guy or woman, whoever, who you've talked to who knows nothing about computers, multiply it by 10 and you've got me. He still dumbed it down and I didn't understand. So this is what I said to him because I was a basketball coach. I said, do you play basketball? He says, no, I don't know anything about basketball. I said, okay. The 1 has the ball. The 1 throws the ball to the 3, cuts to the 2, who sets a flare screen for the 3. The 4 goes across to the 5 and sets a back screen who comes over to the low block. The ball is now in the hands of the 3. The 3 throws it to the high post where the 4 is cut up, gets the ball, turns around. The 3 sets a flare screen for the 2, who's replaced the 1. He goes off the screen, catches the pass, and shoots it. Now, do you got that? And he said, I totally understand where you are now, totally understand. And he explained it to me and took me through it, and we fixed the computer. Second, when you go to the doctor, if possible, go with your wife, a close friend, someone who can record the dialogue between you and the doctor, keeping track that you have asked all your questions and ensuring that when you leave, you have the answers to the questions with you. Don't trust this information to your memory alone. And finally, don't get lazy in your monitoring and your learning, because your prostate cancer, if you choose to live with it like I have, can still progress. But take solace in the fact that there are new discoveries and developments happening all the time that can offer new options or suggest changes in your current way of caring for your cancer. In my case, preparing this little presentation has actually raised a few questions for me about my prostate cancer care plan going forward, questions that I will discuss with my doctor at my upcoming appointment. So stay proactive and stay healthy. Thank you for having me.
Thank you so much for sharing. We have a few minutes if anyone has any specific questions for Mr. Odishu before we move on to our next speaker. Yes.
So, what is your latest PSA result?
The last one I got was, I can't remember if the last one was 2.7 or 2.9, but I've gone as low as 2.0.
Have you had any false negatives? False positives?
I don't think so.
You gotta be proactive. Dr. Google. But be careful with Dr. Google.
I know.
Thank you. I think that's all the questions. I'll let Sharon present our next speaker.
All right, well, I just want to say, sorry, this microphone thingy is new to me. I want to say thank you, Mr. Odishu, for that wonderful presentation. So our second speaker is going to be Mr. James Hatlow. He is a man with never-ending willpower and determination. He has an extensive background in journalism and visual communication. He works full-time at Meta. He is an audio-visual wizard, as you will soon see, and a TRX evangelist. So much so that his enthusiasm has catapulted me to purchase one of these systems. I will have to say, I am not as great as he is at it, but my partner and I get a lot of laughs from watching my son do these exercises. He flies into the wall all the time. Okay, so Mr. Hatlow was diagnosed with high NCCN risk prostate cancer in 2017 and underwent dual radiation therapy, which is a combination of high dose rate brachytherapy and a course of external beam radiation therapy in 2017, combined with long-term androgen deprivation therapy, which he completed in 2019. And as Dr. Batch had already stated, under the umbrella of radiation therapy, there is brachytherapy, which is the delivery of the radiation from the inside out, and external beam radiation, which is delivery of the radiation from the outside in. So with the combination of the two, radiation oncologists can optimize the dose of radiation and reducing the side effects. Androgen deprivation therapy, also known as hormone therapy, is administration of medications that turns off the body's ability to produce testosterone. There's a common misconception that hormone therapy is when we administer female hormones. We don't do that. And with that, please warmly welcome Mr. James Hatlow.
Thank you, Sharon. First, let me see if we can get the visuals functioning. We can. Okay, great. I've just got to make sure I don't get them. Mic level's okay. I asked that. Part of my background also includes having done professional videography. I've taped conferences. If someone offers you the mic, please take it, because it's not for you, it's not for the room, it is for the people on live stream, and it's also for the guy who's going to be doing the post-production later, and someone's, the sound levels go along fine, someone asks a question off mic in the back of the room, and they go down here, and you're going to say, how am I going to get that thing up so this is a worthwhile recording? So please use the microphone for questions, and also I'd like to ask you to join me in appreciation for some of the invisibly hardest working people in the room, because I've been there, and that's the audio-visual crew. My own journey with prostate cancer began back in September 2016. I had an annual physical with Dr. Stephen Curran in Fremont. I've been going to Dr. Curran for years. It was routine in every respect, except he said, your PSA level is up. It's quite a bit up. It had been 2.9 back in July 2014. Now it was up to 6.9. He said, I think you had better have a consultation with a urologist in our group. They were the Washington Hospital Health Care Group in Fremont. So I said, well, okay, I guess so. I made an appointment with Dr. Mark Sala, who was the urologist he recommended. We got that on the calendar for November. At the time, I felt fine. I mean, I think that might be one thing that clinicians might want to relate to people who have prostate cancer diagnoses, or at least high PSAs. You don't feel sick. I mean, there was no indication at all. I was exercising. Somewhere in the past, I'd seen that the baseline for young recruits going into Marine boot camp was to be able to do 5 pull-ups. 10 was better. I thought, my age, if I could do 5 pull-ups, that won't be too bad. So I was working on it. I was running. I was actually able to do, I think, around 8 or 9 pull-ups at that time. I'm in great shape. Okay, doc, so what do you have? So I went to see Dr. Sala, and he explained what the implications of that high PSA level might be. And then he said, really, we can't tell what's going on unless we do a biopsy. Didn't sound like fun, but it sounded like a necessary procedure. So I said, okay, well, let's do a biopsy. And that went on the calendar for, I think, December 15th. And then, meanwhile, I ran the San Jose Turkey Trot fun run on Thanksgiving with my two of my adult daughters and a couple of my grandkids. It was not a stellar performance, but I finished the race, 5K. And then we went on to have, yeah, we're moving. Okay, so the biopsy was on the 15th. It was done under local anesthesia. So I think some of the previous speakers have indicated. Core samples are taken from the prostate gland, which is roughly size and shape of a walnut, and they want to take 3 samples from each quadrant and examine those, at least in my case, that was what they did, for each area to see if there might be malignancies present. It wasn't too bad. The worst thing was that to prepare for that, you have to clean out your system. You don't want any stray matter in the area because they're going in through the rectum, and they don't want any unfriendly bacteria getting into that sterile environment. So I had to drink something that I forget what the name of the preparation was. Some of you may have seen it or even had to use it. It tastes kind of like 7-Up with extra syrup over asphalt. And it certainly had the desired effect. In fact, it had such a profound effect that I think it messed up my digestion for several weeks after the biopsy. This was kind of a preview for at least my journey with prostate cancer, that the cure was going to be a lot worse than the disease. Really, prostate cancer is happy to stay under the radar until it can do its work. That's my opinion anyway. And going through what it takes to get rid of prostate cancer was a lot more rigorous. I went back on December 27th to see Dr. Sala to get the biopsy report. Of course, this is right after Christmas, before New Year. It was kind of, well, season's greetings, you do have prostate cancer. You have, I think they found malignant cells in something like 9 out of the 12 samples. And then the next step would be, okay, how are we going to deal with that? I actually went home. We had a meeting with our family, 4 adult daughters, their spouses, kids, and just explained, Dad's got prostate cancer, so we're going to have to explore that. I would like to say we had tremendous support all the way through this from my family. I think Daniel mentioned the importance of having your wife involved. My wife, who is here, along with our granddaughter, accompanied me on all our doctor visits, took notes as we were doing our research and planning. That proceeded for, did we move? We moved, okay, I've got to move mine. Into March, they wanted to do a whole body bone scan. The point of this was to see whether the cancer had gotten out of the prostate and gotten into the anywhere else in the system, which would be a much more serious situation. In fact, that was not the case. I was relieved to know that. But they had found a nodule on top of the prostate cancer, top of the prostate. It was explained to me the surface skin of the prostate gland is something like the skin of an apple. There was a bump there. So the prostate cancer was thinking about sending out agents to take up residence elsewhere, and as I think some of the earlier presentations have suggested, once the cancer gets outside the prostate gland, it's a lot more troublesome to deal with. In fact, in some cases, long term, it could be game over. So at least we had it in an area where it could be treated more easily. I went back to see Dr. Sala again. He went through various options for surgery, suggested there were also some hormonal treatments, radiation treatments. His inclination was surgery. On February and 13th and 15th, saw another surgeon and a radiologist, respectively. We wanted to do very thorough research, which I think is important in something like this. Dr. Brooks, it was in the Stanford Urological Oncology Department. He reviewed it. He also explained the Gleason score, and I think, as we've seen, it takes a Stanford professor to explain the Gleason score. And so I got at least an idea of what that meant. And at the end, he said, well, in your case, I tilt slightly toward radiation, which was good to hear. One of the other things I had done after first getting the diagnosis was to call an old friend. We'd been on a board at a church together in years past, and he had moved a little bit out of the area, but I knew he had prostate cancer and had dealt with. And I said, so what was your experience? He said, well, I had a surgery, and I was in the hospital for a couple of days, and then on a catheter, and then I was wearing Depends for a few, for several weeks. And some of the stuff has come back, not all of it. My wife and I are okay with that. And I don't know if my wife and I would be okay with that. So non-surgical approach was something that already seemed appealing. Dr. Stephen Kurtzman, who is at El Camino Hospital, who Dr. Sala had, he said they worked together often, was pretty blunt. He said, look, urologists tend to go towards surgery because that's how they're trained. However, 90% of what I deal with in my radiation practice, which was brachytherapy, the implantation of radioactive gold seeds that basically go in the prostate gland and they stay there. The radiation decays, and ideally, so does the cancer. He said, people come to me, they've already had the surgery, and they still need it. So they've gone through the surgery, and then they have to go through radiation. He recommended radiation. And there was a point that Dr. Sala had made that's probably worth mentioning. It came up in an earlier question. If you have the surgery, you can have the surgery, and then you could follow up with radiation. That's a fairly clean procedure. If you have the radiation first, well, now you've got a scarred prostate gland, and that's not as pretty a picture for the surgeon. So that was not something that an area that they would prefer to go. Finally, I came and spoke with Sharon Chin here at Stanford. She described the procedure that we had. Dr. Mark Boyarsky, whose name is not on here, is actually the physician behind that, and he was. He's kind of the sort of the Lone Ranger, like, who was that man in the lab coat? He would come through and speak briefly and say something great, and then he'd have to run off, to another patient. But Sharon explained that there'd be a combination of external beam radiation and then the internal radiation that Dr. Bagshaw described, and then finally a period of hormone therapy. So my wife and I went home and talked about it, and I was thinking, gee, so first you're going to carpet bomb, attack the prostate cancer by carpet bombing with radiation for about a month. Then you're going to send in the SEAL team, and then there's going to be this scorched earth period to get rid of any pockets of resistance with the hormone therapy. You guys don't mess around. So we decided to go to Stanford, and that led to scheduling an appointment, and we went in on August 23rd, actually, was when that was going to begin. Went to the ITA, trying to track with what, yes, thank you. And the ITA was where I got the actual injection. What I don't have pictures of was the waiting room there. And I walked upstairs and went in and saw people sitting in wheelchairs with masks and respirators on before masks and respirators were common for us. Stocking caps on because they'd lost their hair to chemotherapy. I looked around and said, man, I'm in the minor leagues here. This is, well, I have nothing to complain about. I did get the first shot, which brings the testosterone level down. Sharon Chin did the implantation using ultrasound of gold seeds, and these were target gold seeds. These were not radioactive. The purpose is to give when the external beam radiation is administered, and this is something, let me move on to the, so we already had a discussion on the CT scan, which they use to precisely target that. We began the radiation therapy, and you've seen the true beam. What wasn't clarified earlier is the whole, as you see in the diagram, the whole machine rotates around the patient on the table. But the first part of that, there's an X-ray. Excuse me, I'm losing the mic. That identifies through those target gold seed where the prostate is today, because our insides are squishy, and depending on what you had for lunch or whatever, the prostate gland might not be in the same place it was the last time you had your radiation treatment. So by having those target seeds in there, they're able to precisely locate it. The machine rotates around after the X-ray with the beam. It's not visible here, nor was it earlier. There's actually a green laser that is kind of a targeting thing. The actual radiation's invisible, but it's kind of cool. You're saying, wow, it goes around. The reason it's going around is so that no one area gets, other than the prostate gland, which is at the center of the whole process, is getting excessive radiation. And I think it might be interesting to, it's so impressive, someone might want to do a blind study sometime of just turning off the radiation, just having the laser. The placebo effect might be very impressive. Let me go on here. After the external beam, we had the HDR procedures. Those did require that I was under full anesthesia, not because it would be too painful to have those, to experience it, but because you can't move. You move a muscle for about 3 hours. And when people are approaching your groin with sharp surgical implements, it's kind of hard not to squirm, so they knock you out first. As Dr. Vagshaw said, you wake up with catheters. Fortunately, that didn't stay very long. After that, I was starting to experience hot flashes for the first time. That is a consequence of the ADT. The first ADT dose, I forget the medication, the subsequent ones were done with Lupron, which is basically takes your testosterone level to the floor because prostate cancer feeds on testosterone. So I was already getting hot flashes at this point, but my weight was holding fairly well. I think I'd been 141 pounds when I started. By April, I was saying, well, I was still exercising. I could still do some pull-ups. I thought, maybe I can beat this thing. Sharon had said she had one patient who was a marathon runner, kept running through the whole thing. I said, yeah, okay, I think I can. I'm doing okay. I can maybe do that. You can't turn on the television now without seeing some kind of an ad about gambling propositions. You can bet on just about anything today. Word of advice, don't bet against Lupron because pretty soon I started going the other direction. This is November of 2018, and the weight continued to go on. A pastor friend of mine who understood what ADT does said, yeah, it's like you're going to go through menopause. You have weight gain, lose body hair. As your testosterone goes down. At this point, my testosterone level was just 6 NGDL. And the hot flashes, I had gotten in the habit of carrying one handkerchief in each pocket because as one would get soaked, I'd have to switch to the other one. They had asked me to start tracking the hot flashes, and I did. I think first it was about 6 per day. Between mild, medium, significant. After that, it got to around 10 or 12, and after that, I stopped. I just didn't even want to think about it anymore. But I will say, I think that marriage licenses should include a clause that if for husbands, as their wife approaches menopause, they should probably have 4 to 6 weeks of ADT as sensitivity training, because you really appreciate what your wife, or I have my 4 daughters, 2 are entering the 40s, and Dad is going to be really sympathetic if I notice the symptoms of, sure, honey, can I get you a glass of water? I'll open the window for you, because I have an idea of what's going to be happening there. This was kind of this is right after the final, those green dots on the left, or when I got the injections of Lupron at the ITA. And the last one was in May, so they last about 3 months. I think once along the way we had one that lasted 6 months. You can get them in 3 months, 6 month, 1 year. Dietitians, excuse me, I think prefer the 3 months because they can track things better. So that was still in effect, but then where are we? There we are. Thank you. By May 2020, weight was starting to come down. Testosterone now is back up, 346, which is well within the normal range. Starting to get some body hair back, starting to get some muscles back. And Sharon mentioned the TRX. Of course, we were right in the middle of the lockdown. Well, we weren't going anywhere, so I couldn't go to the gym. I didn't much go to the gym anyway, but Byron was, well, as you'll hear, it was a honey badger among gym rats in his day, and I was not in that category, but I needed something, and a TRX is basically a cable or suspension trainer. I had it hooked up in the garage, but we weren't driving. The car was in the garage. There was no room to use it. But it did have a little flange. I could hook it over a door in a closet space, and then I was able to do a pretty good workout in a floor space about 3 feet by 7 feet, and really began getting back in shape. I think I'm getting out of sequence in where, there we go. So eventually I was getting to get the weight down again, get muscles back, and as we run out here, weight was back down to 137, chest hair came back. One interesting phenomenon, I don't know if this has been mentioned, you know, as the guy gets to adolescence, you start getting a little chest hair and whatever, and sooner or later you or your family says, you know, you better start using some deodorant, pal. Whatever those hormones and secretions and bacteria were, somewhere along the Lupron path, they checked out and they've never come back. I have not needed to use deodorant for a long time. And I imagine there's a Stanford grad student out there who will say, you know, if you could take botulism toxin and turn it into Botox, maybe you could take Lupron and come up with something that'll destroy body odor. So just put my name and a footnote on the patent if you actually go ahead and do that. I was able to run the turkey trot again in last year. I they did not run it in San Jose. This was a COVID thing, so you had to run it in an area near wherever you lived. I went to my daughter and son-in-law's home with the other family. They're up in Silver Creek. It's in the hills. If you've ever seen the turkey trot, it's on flat land in San Jose. This was a little tougher, but I was able to run the whole way. And after the last checkup with Sharon, I was able to get the PSA levels are still undetectable. Testosterone is at a very good level, and I'm very grateful for the level of care that I have received here. I would say years ago I had a dentist, great dentist, and he had to sell his sell his practice because he had back trouble. So I went to the lady that bought the practice and was sitting in the chair, and she and her assistant were having a conversation, and I might as well have been a Toyota Camry that they were doing an oil change on. There was no interaction. I never went back. But all the way through my experience at Stanford, there's never been one time that I have had any sense that that I wasn't being cared for, that the outcome was not a priority, and that I was not in good hands. So thank you, Sharon, and thank you, Stanford. Now, I'd be happy to answer any questions.
All right. Thank you so much, Mr. Hatlow. So just for, so we do have a question. Let me.
What exactly determined the end of your dosage of Lupron?
Well, as I think Dr. Bagshaw was talking about that in the hormonal therapy, there is a course of, it was not based on what was happening with me. It was based on, this is the procedure that they have found to be efficacious in terms of how long you need to be on it to starve out any prostate cancer that might still be trying to reestablish residency. Any other questions? Can we wait for the microphone, please?
No, that's all right.
It's not. No, wait, bro.
Let me go back here and then I'll end up front.
Okay. Sir, in the back first,
Yes.
with the microphone.
Could you talk about the mental effects of the androgen deprivation, if any?
Yeah, and had we, I probably made enough notes to talk for an hour and a half, but so I skipped over that. Yeah, it was the ADT. Well, there's different factors. There was a certain amount of fatigue that happened. Daniel very graciously spoke about the sexual performance aspect. Yeah, that definitely had an impact in that area. I would say that let me preface this by saying my wife was formerly a leader at a Bible Study Fellowship women's group. Women would ask her, I know I need to work at my marriage, and she said, no, you need to play at your marriage. You need to have fun. You already got a job. That attitude can extend to the bedroom, and it should. In our case, it was well. Let's see, we're getting it's down to about somewhere 40, 50, maybe 60% of what we used to have here. Well, I guess we can work with that. Hey, we can work with that. So we were able to get through without, there was never a point where I said, oh, my manly functions have deserted me, and just was in despair. Yeah, it was certainly dented. But knowing that there's a light at the end of the tunnel certainly helped, and knowing eventually I was going to be able to get back to some level of what I'd been beforehand. Sir, I think this gentleman's ahead of you.
I'll start here.
Okay. Yes, sir. The Lupron, did you take any other medicine besides, in addition to Lupron? Lupron.
The Lupron injections were given, you had a shot one side or the other every 3 months approximately. No, they were at the time for the HDR, these others, there were certain antibiotics, Flomax for urinary failure, but once we were kind of in the routine, Lupron was it. It was Sharon suggested, well, you might want to try Viagra, Cialis. And I thought, well, maybe. And it's, for one thing, that stuff's expensive. It's not covered by health insurance. For another, I agree with Daniel. I've got enough stuff going on in my body. I'm not going to throw some more chemistry in there. So that was pretty much it.
Okay, so it was Lupron. Did they tell you how long Lupron would be effective?
It was effective for 3 months.
It was only effective for, you only took it for 3 months?
No, let's go back here.
Wow.
Well, actually, I can't go back there on that one. No, it was a period of roughly about from, I think we started the first one in August 2017. The last shot was around May 9th of 2019. And so every 3 months I'd go in and they'd give me a shot of Lupron, and that would keep the testosterone level somewhere in the cellar.
So you took the Lupron for 3 months?
No, I took 3 month doses of Lupron
every
3 months
Huh.
from 2017 into 2019.
How long did you take the Lupron again?
It was, well, to do the math, whatever, from August 2017 through May 2019, however long.
Okay, a couple of years.
Yeah.
Did it lower your PSA?
The PSA, actually, I don't think the Lupron did anything to the PSA. The radiation sure did. It has never come back. My PSA currently is less than 0.05. It had stayed there.
Less than 0.05.
Yeah.
Wow.
Testosterone up,
But
PSA down.
That's 5
good.
times undetectable, a 0.01.
I don't
Yeah,
care.
but it's low enough. But anyway,
It's plenty low. That's what we were going for.
yeah. And did they say how long the Lupron would be effective in stopping the cancer? Lowering the PSA and stopping the cancer.
Well, again, the Lupron, and you can correct me if I'm wrong, we have plenty of medical professionals in the room. The Lupron did not lower the cancer. The point of the Lupron was to lower the testosterone.
Yeah, which lowers the cancer.
Well, I'm sorry, yes, that did.
Anti-sol, anti-testosterone, which anti-prostate.
Yeah, so and the PSA, which would be an index of what kind of cancerous activity was there, was what dropped off, but I think the radiation did that. The Lupron just made sure nothing came back. That was the point, as
Did
I
they
understood it.
mention Luprolide?
We're going to just pause. We have one more speaker, and then after
Yeah,
our
I'm
last
happy to
speaker,
answer
we're going to
that.
have question and answers, okay? You can talk to them more.
okay.
Thank you.
All right, thank you, Mr. Hatlow. That was an amazing presentation. All right, so our next speaker is going to be Mr. Byron Thomas, who is an extremely witty education consultant with a wicked sense of humor. I've had the opportunity to get to know him over the past week. He was born and raised in the coast of Mississippi, which is a rock's throw from New Orleans, which means that he probably grew up on beignets and etouffees, my favorite food, 57 short years ago. Who, like me, also has an unhealthy food affair with fried seafood. He is a proud father of 3 with 3 beautiful grandchildren, initially a New Orleans Saints fan, thumbs down, but he has now converted to a 49ers fan. So, thank goodness, because we almost didn't let him come to speak today. So Mr. Thomas was diagnosed with intermediate NCCN risk prostate cancer in 2018. He underwent a robotic-assisted laparoscopic radical prostatectomy and a laparoscopic bilateral pelvic lymphadenectomy in 2019. And I know that Dr. San touched on this, but robotic-assisted laparoscopic radical prostatectomy is a minimally invasive surgery that removes the entire prostate gland through very, very small incisions. So it's quite miraculous. Please give a very warm welcome to Mr. Thomas.
Hello, everyone, and I want to say thank you to my other 2 panelists up here who did an outstanding job at explaining some really complicated data and data points to everyone. I'm not going to do that because they've already done all of that. For me, this journey started, as she said, back in 2018. I'll tell you, I absolutely loved going to the gym. I don't know what it was. I don't know if it was the smell, the funky sweat, whatever it was. I went to the gym one day, and I didn't work out much for a while. I grew up lifting weights and all that stuff in the South, but when I came into California, I didn't really, everything is on a hill. Everything, you're walking up or walking down, so I just figured, that was good enough. I went to the gym, and I got on the elliptical, and man, this thing was hard. I had the thing set on about 7 or 8, and I was just perspiring like crazy, exhausted. Only 10 minutes had gone by. Next to me was a lady about 78 years old, had hers on 5, and just running. And I can't wait till she gets off, because I want to get off, but I can't get off because she's still going. So, but that was the beginning of my love affair with trying to work out. I freaking loved it. I'd go to the gym and I'd stay for 5 hours. I do 2 hours on the spin class, a beginner's level, and an advanced class. Loved it. Of course, there were people in there that cheered me on because I kept everybody up, going. They got a big mouth. And I love Zumba. Beginners class and advanced class, loved it. There was only 2 men brave enough to go into those classes. And I was glad I was one of the 2 men that was brave enough to go in front of all of these girls that hang out. When I was diagnosed, I was in the best shape of my life. My doctor wanted to give me, I had diabetes. I wasn't taking any medication for years because I changed my whole eating. Don't eat meat. Don't eat anything that's processed by any animals or anything like that. I thought, I'm in the best shape of my life. I had 6-pack abs. I'm telling you, give me a mirror, I could stare at that mirror all day long because I felt that good. Then I go in, and this doctor tells me, well, how's your medicine? I'm like, I don't take any medicine. He says, well, you need to, you need to renew your prescription. I go, for what? You just want to give me some pills. He says, why don't we do a test? I need you to go do another blood work, some more blood work, and I go to do the blood work. It comes back. He says, just as I suspected. I didn't notice it before, but your PSA, I didn't even know what the PSA number was. I had no idea. It was all foreign to me, and I was feeling great. I looked great. How could this thing happen to me? Well, the doctor says she sent you to urology, and they give you some more information, and then my world changed. Suddenly, the gym didn't look as good as it did before. The mirror had gotten a little dusty. We hadn't been sharing any moments together, and the doctor at that time says, well, you know what? You're going to be fine. I'm telling you, if you know anyone that has cancer, and someone tells you you're going to be fine, it doesn't do anything. Nothing. Because when they finish talking, you still have cancer. So I had to determine what I was going to do with that information. As she said, I'm from a weird family. I'm from the South. And we believe, collectively, that we can pray any daggone thing away. And I have some very powerful prayer people in my family, and I'm like, they're going to freak out. The one thing I don't want is someone reminding me every day that I have cancer. I'm like, well, I can't tell that person. I can't tell that person. I can't tell. These are all, couldn't tell my mom, my children, because I didn't want them to worry yet because the doctor said I was going to be fine. I said, I better wait, because if I say this to these people, my mom lives alone in one of my houses, and it's a big place. I didn't want her to be worried alone. I'm the firstborn. So, again, I'm Southern. They take that very seriously. And I didn't want a morning wake-up call with prayers. I didn't want a lunch call with prayers. I didn't want a bedtime call with prayers. I just wanted to just lay for a moment and allow my mind to wrap around what was going on and what my body was telling me to do. So we decided that's what I was going to do. My girlfriend at that time gave me some shelter. I told one of my sisters who I know could keep it, and that was my journey. That's how it started. And everything. I didn't think about sex. The moment I heard it, suddenly I didn't want to go to the gym. Sex wasn't that important to me anymore, unfortunately. Men, that's our identity. I know some of you are probably going, no, it's really not that big of a deal. That's because you're here now. But normally, it's a big deal. That intimacy with your partner is important. And I lost it like that. I'm being real. I was thinking more about what I was going to miss with this diagnosis. And was this doctor as sure as he said he was? Or was he just trying to make me feel good, and I was going to have some kind of abbreviated, what did I call it, success with my prostate and what needed to happen. So the doctor told me, go home, think about it, and let me know what you want to do. What? What kind of decision is that? He says, well, I'll call you in a month or so, and we'll talk about options. A couple months goes by. Mind you, when you have cancer and you're waiting for information, you're waiting on pins and needles. You're waiting for that phone to ring. It's not like, some of us, you meet that special someone, you get the number and you call, damn, he didn't call me back, but I know she's going to call. I really want that. And that's what I was thinking. This doctor's going to call me. doctor called me. We set up a date to chat, and we decided that I was going to have the surgery. He says, you know, we had done the biopsy. I'd come here. They'd done all of that. And I was like, great, let's get this thing done next week. He says, well, it's not quite that simple. He says, you still have some time. You could think about it, and you can let it go for a year, and we'll see how, because it's going very slow. Psychologically, for me, waiting for a month, 2 months, a year, it just wasn't possible. I thought I was healthy, but this information made me psychologically unhealthy. And so I decided that we're going to do the surgery. They set the surgery up 6 months down the line. I was sweating bullets. I'd go to the gym. I could only stay there for 2 hours because I just couldn't find enough things to occupy my mind to make it palatable for me. I'm like, oh, gosh, you know, what do I eat? You go home, what do you eat? What's going to make the cancer grow? What's going to keep it at where it is now before that time comes that you have to do the surgery? And so for me, that was the challenge. But after the surgery, things went pretty well. The surgery, you know, that robotic process, you got these 5 different holes all over you. When they go in, it's pretty simple. You walk out of there with a catheter, and your testosterone numbers are really, really low. Of course, everything is low, you know. There's no sexual function for quite some time, as a matter of fact. So many of us think about that. You learn new ways to make your partner happy. And like my good friend Dan was saying over here, you know, you can take some cues from this guy because he really committed to it, and that's who we have to be now. But that's who we should have been before. But now, it's different. And so for me, that was part of my recovery. Learning new things about myself, learning what I can do, what I'm capable of, and what my future looks like. For me, it's all about the end result. You know, I could have stayed, I could have kept the cancer and have a wonderful sexual function, and I was, you know, had no problems whatsoever. The wind blowing, everything's great. But I'm happier now that I've had the surgery because I'm healthy now. And that's what this is about. And when you first get the news, psychologically, you go to an unhealthy place. You start thinking about things that, wow, that's not so good. I don't want to think about that outcome. What if? But once you get past that, your mind, your body, your soul starts to heal itself. Because you start off, you're in the mud. And it's not until you decide that you're going to get out of the mud to clean yourself off, does things get better. And that's where I am. I'm out of the mud. I feel better. I'm getting my functions back. I'm not, you know, we don't get 100% back, and that's what the slide tells you. You're lucky if you can get 60%, but that's okay because I'm here to tell you about it. Now, there's a lot of other things that make life worth living, but not having cancer is one of the biggest ones. So I want to thank you all for inviting us here and giving us an opportunity to share some of our stories with you. If you have any questions, I want to keep mine short so that we wouldn't go too long. So thank you very much, and I appreciate you.
We have about 10 minutes for questions.
The screen there says that in 2019 you had pelvic lymph and whatever. You had your lymph nodes extracted. Could you say something about that, please?
Yes. So the lymph nodes was taken because my cancer was in the center of my prostate, and it wasn't near a wall. But to be sure, they take the lymph nodes just in case there was a possibility that it might have spread to the lymph nodes. That's all I know. They tested it. After that, there was no cancer in my lymph nodes at all. The cancer had not spread outside of that small little place. We did MRIs. The MRI could not detect my cancer. it detected spots in my prostate, but they were not the spots for cancer. They were just a spot. And I received the diagnosis. So in 2012, as it said there, I had high PSA levels then, but the doctor didn't notice it. I don't know what I'm looking for. So I didn't notice it myself. It wasn't until 2018 when I didn't want to take any more medicine. My doctor was like, oh, come on, we took this other test, and he noticed the PSA level, and that's when the stuff hit the fan.
We can actually open up questions to any of you all, if you don't mind. So I can come and have you ask, follow up with you on your question from earlier. To Mr. Hatlow, there was a question in the live chat. What was your Gleason score after your biopsy?
I have no idea.
Okay.
I didn't follow
Fair
that.
enough.
Yeah, I was really tracking with the testosterone levels, PSA. I don't actually recall getting a the Gleason score after the biopsy. I think it was around 7. But again, it even with the explanation today, the kind of the calibration and calculations of Gleason scores are a little above me. So I wouldn't swear to that, but it was enough to persuade Dr. Sala to say we should proceed with some kind of treatment and not go into active surveillance. He said, we could wait 10 years and see what happens, but if it keeps going in 10 years, it'll be too late to do anything about it. So let's act.
Thank you. Here you go.
I have a question for the gentleman on my left here, same one. After you finished the Lupron therapy, how long did you start to notice that your muscle mass started to return?
Well,
And the reason I'm asking the question is that my golf game has been hurt by my Lupron. Here, I don't get the same yardage I used to. So that's really the basis of this. But what's your experience with that?
Well, there's definitely a trough. I mean, I think I mentioned I was, before this all started, I was able to do 8 to 9 pull-ups, which, I mean, I did other exercises, but that was the toughest one, so that was a good benchmark. Got down to, in the depth of the whole Lupron experience, I could hold on to the bar if I was lucky. That was about it. Couldn't do any of them. Now I'm back where I can do about 10 again, but it took. The last Lupron shot was May 9th, 2019. That was good for 3 months. So let's go out 3 months from there. Theoretically, it started wearing off. I didn't notice a precipitous drop. It took a while. I kept exercising. And by about a year out from there, I would say, yeah, the Lupron effects were in the background, in the rearview mirror, and as the testosterone levels returned. I would say after about a year that it should be no longer having any effect. But it does take. I did find being active and trying to exercise did make a difference.
We have time for one more question. Anybody? Sorry. Here, wait. Let me bring you the mic.
Would they remove your lymph nodes? Or would they, you said they removed your lymph nodes?
Correct.
What are the side effects of that?
Wow.
I mean, what?
I'm not sure I can
Did you feel any different, or?
I didn't notice a difference. During that time, you're just healing. It takes quite a while. I thought I'd be back up and running in like 2 or 3 months.
Right.
Wrong. It takes over a year of, trying to do the right things, eating right, and of course, consulting with your doctor. There may be some medications that might help you in some situations.
Right.
And so that's where I was. I didn't miss the lymph nodes because I didn't know what it would not give me. I didn't understand what its functionality when it came to my prostate and the cancer and it being removed.
Right.
I really didn't know. It's one of those things where I wish I'd had someone like me that had already been through it to kind of talk it out like we're doing now, because it really does shed a lot of light. Even the information that we've received here today, it really does kind of open my eyes to what the process looks like.
Right.
As my friend Dan here said during his time speaking, is that we don't know what we don't know. We don't know what to ask, what symptoms,
Well, yeah, men
what
don't
that
talk
process
about
looks
this
like,
subject.
and what the side effects are going to
Yeah.
look like.
Yeah.
You don't know
Yeah.
unless you understand what kind of questions to ask. So fortunately, he had your team with you. Jim had his team to kind of help him throughout the process and help narrate it, help document it. I think that was probably the best approach, to have someone with you to kind of help you put those things in perspective, because you can't think of everything yourself. Your mind is consumed with the what ifs, that you might find on Dr. Google, so. I wanted to say one other thing too, is that I had an awesome experience with Stanford. I met a nurse practitioner or RN that made me feel, I'm telling you, I went in there, I wanted to cry. As a man, I'm trying to hold back the tears because this has changed my life so much, and it's hard to even talk about it. And this little tiny nurse put her arms around me and said, it's going to be okay. And I'm telling you, it was like a freaking angel that just kind of coveted me and made me believe that it was going to be okay. And that lady is Kate. She's in here right now. Catherine is her name, but they call her Kate. She is super wonderful. She made the process easier.
Question.
Just,
All three gentlemen, do you find yourself constantly trying to translate doc talk to patient talk? Huh?
yes.
That's half of the mental block in understanding the whole thing.
It's a lot to take in.
It's like a barrier between the patient and the doctor. Because they use their doc talk, you gotta translate it to patient talk so you can write it down and understand. If you can write it, you can understand and remember it. But you gotta get over that barrier of them taking words like prostatectomy, oh, this is surgery, laparoscopic. Who the hell knows what these words mean to begin with? Come on, we're not docs.
You're right.
We're on the
You're
other
right.
end of the stick.
I might have a slight advantage there. My stepfather was a pediatrician, late stepfather, who actually
I'm sorry, can you speak up a little?
Sure. I was saying my stepfather was a pediatrician, actually graduated from Stanford many years ago, so long ago that he worked his way through school, helping build the first Stanford Stadium. But I've also done a lot of technical writing, and I'll say that engineers are in the same category. You basically have to listen, and a lot of times you have to look up what you heard to understand, because people who are immersed in technical jargon tend to speak out of habit in technical jargon, and the context is fine for their peers, but the rest of us, we're a little out of that loop.
No, it's important that docs use their doc talk and write it down that way, but so they can communicate with each other. But when it comes to explaining, they don't have time to explain anything. It's a business, okay? Mm-hmm. That's been my experience. Mm-hmm. I go to the VA, but anyway. But trying to translate everything into doc talk and make it simple. The whole thing is about making it simple. And I've found overall, number one is to find the cancer early. And number two is to stop it early. Any kind of cancer test at all you can get it. Because a lot of these cancers, there's no symptoms. And by the time they find it, hang it up.
Well, thank you so much for all of your questions, and thank you so much for our fine panelists. I want to thank everyone for coming today, and a special thank you to our patient panelists. For being very honest and being very courageous to come up here to talk about their experience, right? And it allows us also to gain some perspective as well. Being diagnosed with any cancer, right, is scary. But being diagnosed with prostate cancer brings along special circumstances because there are so many different types of treatment modalities that are out there. And it's difficult sometimes to weed through everything, and it's a challenge to find what treatment modality is like best suited for you, for your family, for your lifestyle. So for those of you, it's important, ask those questions. And I know lots of doctors go, oh my God, don't Google it, right? Google it, because it's gonna give you something that says, oh, well, maybe I should ask about this, right? And those questions are important, because if you don't ask that question, then you might not get a question that you're supposed to ask. Anyways, so definitely don't be shy, always advocate for yourselves. And once again, thank you everybody for being here. I would like to go ahead and transfer all of this over here to my wonderful colleague, Charlene Chow.
Hey guys. I don't think you guys have met me yet. My name is Charlene. I'm a physician's assistant in urologic oncology on the surgical side. So thank you all for being here. I hope you guys have enjoyed the program so far. We're gonna let you guys break for lunch, but before you do that, right after lunch at 1:15 is when the breakout sessions will start. So don't come back to this room. The breakout sessions are 4 different sessions. As you guys can see here, we're focusing on nutrition, incontinence, erectile dysfunction, and then how can we support you guys mentally and emotionally throughout all of this. So please choose the one that is most interesting to you guys. You can bounce back towards different rooms. The rooms are going to be, if you exit this, I don't know what this is, room, turn right, and you'll find the rooms along the far wall. So they're all right next to each other. So I hope you guys enjoyed it. To the gentleman who asked about the lymph nodes and if there are any side effects, we don't remove enough lymph nodes for you to feel an effect from that part of the surgery. Lymph nodes are located throughout your body, and they're basically the garbage men of your body. They get rid of all the trash. But because we remove such a small amount, and these are located in the groin area next to the prostate, you won't feel it at all. Your body will figure out other ways to divert the bad stuff and get rid of it. Okay? And I think it sounds like there are lots of other questions, so you guys can also please enjoy your lunch, and I think we're going to continue questions during lunch. Thank you, guys.